This is our first lecture for BMS 291, and it's a simple introduction to pathophysiology and pharmacology, largely terminology, and a quick revision through homeostasis. So we'll get started. So in this subject, we're going to have to master a lot of terminology. No matter the specialty area of health you work in, you are probably, for quite a large part of what you do on a day-to-day basis, whether it's working with a health team or deliberately just working at the coalface with the patients, you end up acting as a liaison. So you're always doing that translation between the highly technical language down to the patient's understanding. Diagnostic reports use this terminology, the physicians use this terminology, the specialists use this terminology. So one of the tasks I challenge you to do is to create a list of terms. Each time you come across a word you've not seen before, write it down, write out a definition, and spend the time actually memorizing what the terms mean. So you should have a list of terms to put with your study questions when you're working, or your answers to your study questions, when you're working with things like the multiple choice tests and when you're working with the studying for the end of session exam. So having a look at this first slide, and it is really seriously just about terminology. The word etiology is the first word on the list there. If Oxford Cambridge English spells it with an A, the Americans spell it with an E, any of the international language textbooks spell it with an E, and it is the study of the cause or causes of disease. And we break that down into other categories, such as iatrogenic. So iatrogenic means that the medical intervention has caused or the disease process is a distinct result of the medical intervention. So such as when you're cleaning up a wound, or somebody has had surgery and then they end up with an infection. So the infection has occurred because somebody's broken the skin deliberately to do the surgery and introduced a microbe into the wound. Idiopathic, on the other hand, is actually cause unknown, and there's quite a number of circumstances where we have some suspicions of what causes the disease. We know something about the linkages between disease patterns, but we can't pin it down to a specific cause. And so that sort of thing can, if you've had a look at things like metabolic syndrome, where there's a whole series of symptoms and signs that go together that have to do with high blood cholesterols, hypertensions, middle of the gut waist expansions, pre-diabetic, those sorts of things. We call them a syndrome because they're a collection of signs and symptoms that we recognize as going together, but we haven't pinned down a specific cause for that particular syndrome. And so this is where sometimes a cause is not specifically known, and so we refer to that as idiopathic. So etiology, study of cause or diseases, and we either list them as idiopathic, where we don't really know, or iatrogenic, where it's the consequence of some sort of medical intervention that we've in fact used or been utilised with a patient. Now, the word pathophysiology itself, before we get to the term pathogenesis, physiology is studying body function, and pathophysiology is studying body function when the normal sequence of events has been altered by some disease state. So pathogenesis is where we're actually describing the mechanisms and the progression of a disease, so how homeostasis is disrupted to lead to a condition that we recognize as a disease pathway. And And of course then we start talking about medical intervention. So a medical intervention is any mechanism we apply to try and assist the body to come back to homeostasis, in recognition of the fact that sometimes we're not going to be able to do that, and it becomes more about quality of life rather than returning things to normal. And so then we're talking about interventions to maintain the quality of life for the patient. But we know they're not going to get back to where they were before the disease process started. And that's the whole discipline of palliative care. Now, manifestations is a term you're going to see used fairly often, and signs is something we measure. So a manifestation that is a sign, manifestation is how the patient presents, so a sign is something we can measure. It's things like body counts and body temperature and blood cell counts and blood pressures and anything that we can actually measure is a sign. Whereas symptoms are what the patient feels. So symptoms are very subjective. You can't actually get in and measure pain. You can ask a patient to reflect and give you some indication of how painful something is, but you can't actually get in there and say, well, that's definitely pain. So the same thing around fatigue, and fatigue goes with many conditions. I mean, if your heart's not pumping properly, you will be fatigued. If you're running a temperature, you will be fatigued. And so fatigue comes in many forms. There are many different surveys to measure fatigue in chronic illness, but none of them can in fact turn around and pin it down to something that we can physically measure. We can get an indication of it, and it's a subjective indication. Whereas these signs that we can measure are what we call objective. We can actually measure them. We know that a blood pressure is what it is. We know that a body temperature is what it is because we can measure it. And then the last bit on this slide is about epidemiology, and I pronounce it that way because I need to be able to spell it. And so epidemiology, you'll hear people pronounce it slightly differently, but roughly that way, is all about the patterns of health and disease. And you can go on sites like the ABS website, the Australian Bureau of Statistics, the Australian Institute of Health and Welfare, the Cancer Council. They have loads of statistics out there that you can access and start looking at to see about things like the incidence rates within a particular region for a disease. So incidence means the number of new cases diagnosed within a particular period, whereas the prevalence of a disease is the total number of cases, so those that exist and those that are occurring now, so that within a particular period. So if we were looking at the last year, the prevalence would be all the ones that occurred in January, all the ones that occurred in February, up until today. And so whereas the incidence, we might turn around and say, okay, the new cases diagnosed today. The two words that I find people mix up are morbidity and mortality. And if you can remember that mortality is about the death rate, and we are all mortal, we will all die someday, so mortality. Whereas morbidity is about the impact of the actual illness or an abnormal condition on people's quality of life, so that incidence of ill health in the population. So there's some terms that we will be using regularly throughout the course, and so I'm just going to go on and start talking about homeostasis and what normal is on the next slide. Okay, so the difficulty with some things is knowing exactly what normal is, and the definition for homeostasis is about the maintenance of stable, constant conditions in the body despite changes in the environment. So it's all about those negative feedback loops that actually bring the body back within the normal or reference range. Now, the example on the right there has to do with pH levels, and the normal pH range for blood plasma is going to be 7.35 to 7.45, and notice the graph is indicating that it fluctuates a bit during the day, and of course that depends on food intakes and several other things as the body keeps resetting it back within that range. We know that if the pH ends up too high, then the blood is actually alkaline. We know if the pH gets too low, the blood is actually acidic. And if you remember from your level 1 science, acids actually denature proteins, so they cook proteins. So we really don't want the blood becoming acidic. But just a word around normal ranges and these values that we have. I mean, we've been measuring things like blood pressures and pH and blood counts and things for many moons, decades, possibly centuries, to know something about these objective signs of when the body is truly managing to balance its internal environment, and so is maintaining homeostasis. But some normal ranges can vary according to population. So if I turned around and looked at the tall Maasai warriors of Africa and the pregnant mothers there and used an ultrasound to look at fetal growth and was using things like the length of the arm collagen, or the length of the arm cartilage, or the circumference of the head from the ultrasound to calculate the growth size and things of that fetus, and then used exactly the same measures on somebody who is a much smaller build, such as somebody who's grown up in Vietnam, who's quite small, and has that different heritage, then the normal ranges are different. And so we do have localized normal ranges for things according to the mix of people within any one population. And so some of the pathology labs and things actually do check that their normal ranges that they're using for the population that they're servicing are in fact close to the ones that are published in all our textbooks that are an average of everybody. But we do need to remember that the textbooks are talking about an average of everybody. So on this slide, I've put some reminders up about fluid balance, because we do in fact have to look at electrolytes and fluid balance later in our course. So this is an example that's staying on target when we're reviewing homeostasis. We need to think about the compartments of the body, the plasma, the interstitial fluid, the intracellular fluid, the extracellular fluid, and that total body weight that is water. We've got fluids moving between those compartments all the time. So we have fluid moving out of the blood into the intracellular fluid via the interstitial fluid and then back into the blood. And so we always have this fluid movement. We also have waste movements and we have nutrient movements. And one of the things to remember is that wherever sodium goes, water will follow. And of course we have a sodium-potassium pump in our cellular membrane that's going to look at maintaining sodium on the outside of the extracellular membrane with potassium on the inside of the extracellular membrane. And that balance of that going on is about keeping the amount of fluid in the cell appropriate. Okay, so this is the first of our flowcharts, and it's about fluid balance, and this is the very basic one that doesn't mention the hormone names and things, which we'll do on the next slide. For the moment, ignore the bit in red that I've typed on there with the arrow and the thirst box stimulated, and just look at the flowchart as it is written for normal compensations. So at the top there we've talked about, or the graph, or the graphic talks about normal levels of fluid, and then talks about a loss of homeostasis where the fluid levels decrease. And of course once the fluid levels decrease, the blood volume gets a little low, but also any electrolytes that are in the plasma or in the CSF start to become more concentrated. And so the neurons in the brain, the chemoreceptors, pick that up, and the baroreceptors in the aorta will turn around and pick up the drop in blood volume. So we've got mechanisms there that are feeding information back to the brain saying, hey, the fluid volume is dropping, we need to do something about that. And so what the brain then does is trigger the thirst center, and by triggering the thirst center we will go and drink. What it also does though is cause the hypothalamus to tell the pituitary to release hormones that will help us retrieve fluid. And in particular, these hormones are going to work on the kidneys so that the kidneys start pulling more and more fluid out of the filtrate that has been created to make urine. And by doing that, we have both fluid going in through drinking, and we have fluid coming back into the fluid compartments through the kidneys retrieving more water out of the urine filtrate. And so we come back to normal. But if you look at circumstances where the thirst reflex isn't working, so we know in our elderly population sometimes the thirst stimulation doesn't work particularly well. It's one of the reasons why in the nursing homes you'll see them go around with the tea trolley on a regular basis to make sure everybody's got their cups of tea and that there's fluid with lunch and that everybody's had fluid. And part of that is because the thirst centre doesn't necessarily respond at the same level as it would if you were 20 years old as compared to being 95 or 100. So if we're not going to have that thirst stimulation happening properly for whatever reason, then that fluid intake's not going to happen. Well, the kidneys can only compensate for so long. And if there's no mechanism putting that fluid back, well, the kidneys are going to run out of fluid, that water that it can pull out of the urinary filtrate to bring that blood volume back up and to change the osmolarity of the electrolytes in the plasma. And that has an impact on our cells. You might remember doing an experiment with osmosis where the higher the concentration of the electrolytes within the cell, if the membrane is semi-permeable, then the fluid will move in to dilute that back to a normal dilution effect until both sides of the membrane have the same concentration of chemicals on either side. So we're relying on that to some extent, that osmotic process and the diffusion processes, to have water move into the cell if the cell becomes dehydrated. But the fluid's got to be there to do it. So if there's a failure to satisfy the thirst, either because the person doesn't drink or because there's no available water to drink, or there's no available medic with a saline bag to put an intravenous drip up, then the kidneys will only replace for so long. That point the blood volume drops, the intracellular volumes drop, the interstitial volumes drop, and it will lead to death. So let's now have a look at how the hormones work to help that process. So now we're looking at a flowchart that is about blood pressure homeostasis. So this is about maintaining the cardiac output. And if you remember from your previous studies, cardiac output is equal to stroke volume times heart rate. In order for that to be maintained, we need a certain blood volume. So if we find that we're losing blood volume, then blood pressure will decrease, such as somebody bleeding out, or other reasons for losing blood pressure, such as the heart not being able to pump correctly, will cause a drop in blood pressure because of that equation. Now, the loss of homeostasis on normal blood pressure means the blood pressure will decrease. And there are several mechanisms that will work in concert to try and bring the blood pressure back to normal. Now, the kidneys are really, really keen on maintaining their filtration rate to get rid of toxins. Very important that we clear them out of the body. So the kidneys monitor blood pressure, and if the blood pressure drops, they will release renin in order to cause angiotensin II to be released, and angiotensin II will cause aldosterone release. And aldosterone is responsible for retrieving sodium from the urine, and wherever sodium goes, water follows. So if aldosterone's been triggered to act on the kidney, and remember that aldosterone comes from the adrenal gland, if it acts on the kidney will retrieve more sodium and therefore retrieve more water, and that will help bring the blood volume back to normal. At the same time, there are signals coming through from, because the blood pressure has dropped, that have told the hypothalamus to release antidiuretic hormone so that antidiuretic hormone will act on the kidneys in order to cause water return. So water will be returned back to the blood volume. Now, angiotensin II and to some extent antidiuretic hormone both have peripheral vasoconstriction effects. Angiotensin II is very potent at doing that. It's very good at causing peripheral vasodilation. Both those things will increase the amount of blood going back to the heart, and when we cause more blood to go into the ventricles of the heart, it's a bit like the rubber band. If you stretch it more, it will rebound harder. So not only are these two hormones acting to return the blood volume back to normal, the heart itself is being caused to pump harder so that it then brings the cardiac output back to normal. Now, the other effect in here is that the neurons in the brain and the major blood vessels do pick up information that tells the heart about heart rate. Now, the heart rate is normally pacemaker, so the pacemaker being the sinoatrial node, the pacemaker sets a steady rhythm for the heart rate. But the brain can turn around and send messages via the cardioaccelerory nerve to the heart to increase the heart rate. So there are mechanisms to increase the heart rate as well as increase the stroke volume in order to get the blood pressure back to normal. And certainly if you have a circumstance where the fluid loss is not stopped, so notice I've said in the red box there, fluid loss not arrested, so the fluid loss is not stopped. If it's just about dehydration, yes, the blood pressure will fall and we can rehydrate the patient. But if that fluid loss is because you're bleeding out, because there's been an artery cut, then the heart will be trying to maintain the cardiac output by increasing the heart rate. And so you'll find that somebody will start to be beating their heart much, much faster in order to try and compensate for that lack of volume. So remember the equation, stroke volume times cardiac heart rate, and I'll see if I can actually type it onto the slide. Now, I've been talking about negative feedback loops that bring everything back to a normal circumstance on a fairly systemic level. So throughout the body, these operations that are working in concert, these processes that are working in concert in order to bring the body back within the normal range. But homeostasis can be happening at a local level too. And the two images that are on screen at the moment are talking about wounds to the skin and how the healing process closes over the hole in the skin and repairs the skin. And of course a similar process happens in blood vessels, which are the diagrams on the right. So if we get a damaged area in the lining or through a vessel, then again we have clotting mechanisms and things that act at a very local level in order to repair those areas. Now, if that hole in the vessel was not closed over, and like in the example before where I was talking about somebody bleeding out because an artery is cut, what we're seeing there are positive feedback loops that if they're not stopped, then they will lead to death. So a negative feedback loop is bringing things back within the normal range. A positive feedback loop is what's happening when something has disrupted that negative feedback loop, and so the damage gets reinforced. So in this subject, we're going to talk about the drugs that can help us bring those feedback loops when something has disrupted them back to normal, or at least close to normal. So this subject is all about pathophysiology, that disruption to the feedback loops, and the pharmacology, so the interventions we use to actually, the drug interventions we use to actually try and help the body get back to normal homeostasis. So the study of pharmacology is all about study of drugs, and many things are drugs. Alcohol's a drug, codeine's a drug, caffeine's a drug. So The study of drugs includes everything that's legal, illegal, over-the-counter, which is OTC, or prescription-only drugs. Now, we're not going to spend time around the categorization that is, the S1 through to 8 drug schedule that decides who can prescribe and who can't. But we will have a look at adverse drug reactions and how they're categorized and that sort of thing, and we'll start to do that shortly. So there are two new words that you need to learn. One is pharmacokinetics and the other is pharmacodynamics. Pharmacokinetics is all about how the body actually affects the drug once you swallow it or it's injected. Pharmacodynamics is all about what the drug actually does to the body. So that's its mechanism of action, how it actually achieves what it's intended to achieve to help the body go back to homeostasis. And so we'll spend quite a bit of time looking at those two distinctions. We do pharmacokinetics and then we'll look at pharmacodynamics. Chemotherapy. Every time we give somebody a drug, we're actually giving them chemotherapy. However, the term itself has been hijacked as and shortened to the word chemo, and so often if we refer to chemotherapy these days, we're actually referring to anti-neoplastic drugs, so the anti-cancer drugs. So as much as chemotherapy is a generic term, we've given it almost new meaning in that we now use it to refer to anti-cancer drugs. When we look at things like contraindications, we're looking to identify the populations that should not be given a particular drug. And of course you would know that in pregnancy most drugs are banned. We don't give people many drugs when they're pregnant for the risk factor involved in that most of the drugs, when we turn around and do all the drug trials, they're drug trialed on adults. They're not drug trialed on fetuses for obvious ethical reasons. And so that means that there are many drugs out there that we suspect might cause a problem with fetal development, but we don't necessarily know how severe or which period of time within the pregnancy, etc., that would cause a problem. So in terms of pregnancy, drugs that can be used are pretty limited, but there are other circumstances where we wouldn't give particular groups a particular drug, such as giving somebody who is in renal failure the antimicrobial gentamicin, because gentamicin actually causes renal failure if the doses get too high. So there are issues around when we can give a drug to somebody and when we can't, and we talk about contraindications or precautions in when we give a drug. Prophylaxis is another term that we'll come across. It's when we use a drug to prevent a disease process, and certainly antibiotics have been used in a prophylactic way. If you have major surgery, you might find that they give you something like an antibacterial or an antimicrobial in order to make sure that your wound doesn't become infected. If you are traveling overseas into a malaria area, you will be given drugs before you leave to start taking, so that if you are bitten by mosquitoes that are carrying the malarial parasite, that the malarial parasite doesn't get a chance to actually start using you as a host to grow more parasites. And that, of course, brings me back to things like the contraindications. Some of those drugs that are used prophylactically from malaria, you can't give to a person who is pregnant, which is one of the reasons why they don't let, or they try to avoid pregnant women actually traveling in malaria areas when they're late in the pregnancies. So there's all these things that we need to be used to the terminology for, so that when we pick the drug databases up, we have some sense of what the words mean. Okay, so we're going to talk about naming for the moment. The example I've got on the screen is amoxicillin. amoxicillin is the generic name of the drug. It is a contraction of its chemical name, which you can see there as being quite long, and I've highlighted the red bits that contribute to the drug's name. Not all drugs are named in that way, but many are. And of course, the last thing we want to do when we walk into the chemist is actually ask for D-alpha amino p-hydroxybenzyl penicillin. It's much easier to walk in and say, can I please have a box of amoxicillin? But the thing we really need to remember is that amoxicillin is the generic name or the non-proprietary name, and it tells us something about that particular drug. In fact, the cillin on the end is in fact telling us that it's got to do with antibiotics. But amoxicillin has been around on the market for decades, and because of that, it's now made by many different manufacturers, and so it has many trade names. And so you can see there, you can buy it as Alphamox, you can buy it as Amoxil, you can buy it as Silamox, you can buy it as Physamox. So there are all these other trade names out there. So in this subject, so that we always know what the active ingredient in the drug that we're talking about is, we will use the generic name, not the trade names. Now, the other thing you'd notice there is that all the trade names of the drugs have a capital letter, and that's acknowledging their copyright, their patents rather, for the drug. And so they get a capital letter. But whenever we're talking about the generic drug, the non-proprietary name, there's no capital letter at the beginning of the word. Okay, and using that simple standardization helps us know when we're reading something that's unfamiliar that we're dealing with a generic name, because there's no capital letter at the front. Now, the table that's on screen at the moment will be in very small print, but it is actually in your textbook, so you don't need to print this out large. Just go and have a look at your textbook for that particular table. The reason I've put it there is so that you can notice the namings that are occurring. Most drugs within a similar group have similar name ends or prefixes to their names. So all the drugs that act on LDL cholesterol, on liver cells in order to help you get rid of bad fats from blood, all end in statin. Okay. All the drugs that act on angiotensin converting enzymes to inhibit them all end in pril. So captopril, ramipril, enalapril, they all end in pril. So the suffixes and prefixes in the drug names give you some idea of the drug group they belong to, and we're going to talk about the drugs according to their drug groups a lot. But there are a couple of circumstances where that naming section doesn't necessarily tell you what it expects you to tell you. And an example of that is where we start talking about antibacterial antibiotics that are also anti-cancer antibiotics. Not so much also, but are named similarly to anti-cancer antibiotics. And you'll notice the example there, I've got the antibacterial is clarithromycin. The anti-cancer drug is bleomycin. The reason the both words end in mycin is because they're all produced from bacteria, so that we're actually using bacteria to make the drug. The problem about that is that you wouldn't give somebody with Staphylococcus aureus infections bleomycin in order to kill the Staphylococcus bacteria, and that's because bleomycin is very toxic. But it's really good at stopping cells replicating, so we give it to patients who have cancer. So the prefixes and suffixes give you a good indication of what things belong to, what drug groups they belong to, which the drug groups tend to have a common mechanism of action. However, every now and then there'll be one that doesn't quite fit the rule. Okay, so what I've put up on this slide are some examples, some actual drug boxes, so that you can see what I've been talking about in terms of naming. If you have a look at the boxes on the left of your screen, which are all the irbesartan boxes, you can see there are multiple trade names for the same drug, but the active ingredient in all of those drugs is irbesartan, and they all have the same dosage rate. What would be different between each of those formulations are things like the things that make the tablet hard, the things that make the tablet, easier to swallow. So it's those sorts of things that can be chemically different between those different trade-named drugs, versions of the drug. But the active ingredient is the same in all cases. Where it becomes different is where you're looking at the set of boxes in the middle. So all three of those drugs are used to treat high cholesterol, so hypercholesteremia. And you'll notice if you read the names on the drug, you might have to print it a little bit better. One of them is atorvastatin, one of them is simvastatin, and the other one is pravastatin. They all end in statin, so they are all similar drugs with a similar mechanism of action, but they don't all have the same dosage rates because they're chemically different. And we're going to talk about, how we measure that in order to work that out in the next lecture. But something to keep in mind, they all end in statin, so they're all used in the same way clinically. And the table on the right is to give you some idea of just how often these drugs are in fact prescribed. The leading drugs that are prescribed the most. So the table gives us the top 10 drugs counted by the number of people taking the standard daily dose every day per 1,000 of the population in Australia. And if you look at the top 2 drugs, they're both statins. So lipid lowering, so anti-cholesterol drugs. The next one is a drug given for hypertension, so it's an antihypertensive, and it ends in pril, so it's a angiotensin converting enzyme drug. The one after that is paracetamol. So paracetamol is 4th on the list. The one that comes in after that is irbesartan, which are the ones in the boxes on the left, and again it's used to treat hypertension. Then we have an anti-anginal. Then we have another ACE inhibitor antihypertensive, so ramipril. Then we have the ones for esophageal reflux. And then we come back to another lipid-lowering drug. So you can see simply by the drugs that are prescribed what the most common treatments are being given and what the most common illnesses are out in the community. We're either dealing with high cholesterol, we're dealing with hypertension. Chances are many of the patients taking antihypertensive drugs are also taking the lipid-lowering drugs. Then we're dealing with gastric reflux and a certain amount with angina. So it's important to get a sense of the namings because it helps you turn around and say, okay, well, there's 1, 2, 3 different lipid-lowering drugs on that list. There are 1, 2, 3, 4, 5 different antihypertensives on that list from 3 different drug groupings with 3 different mechanisms of action. Okay, so we're going to finish up with a little bit more on terminology to do with pharmacology, and one of which is how we use the term tolerance. So drug tolerance is where if we give a person the same dose regularly, eventually the effect of the drug will drop off. And so in some circumstances, they will turn around and change the amount of drug they're giving, such as in opioid use, such as morphine in cancers and that sort of thing. Drug dependence, when we get down the bottom there, is a very different thing to drug tolerance. And drug dependence is something that means that you can go about your daily tasks as normally as possible. And it doesn't just mean being dependent on illicit drugs or illegal drugs. Patients who are hypothyroid, who have had thyroidectomies, need their thyroxine every day. Without their basal metabolic rate being maintained by the thyroxine, they will eventually end up very, very ill, very, very fatigued with myxedema, and they will die because they simply cannot function without a normal basal metabolic rate. A type 1 diabetic needs their insulin with every meal because without it they can't move the glucose from the blood into the cells so the cells can use that glucose. And so there's a whole swathe of symptoms that go with having high blood glucose and not managing blood glucose levels. So they're very dependent on their insulin. So drug dependence enables day-to-day survival. Tachyphylaxis, on the other hand, is where you're getting a diminished response following repeat dosing of the same drug concentration. And it means that even by turning around and giving the person a larger dose of the drug, you will never get to the point where you get the same effect as you did with the initial dose. And so transdermal glyceryl trinitrate, so your GTN patches that are given to patients who suffer from angina, they actually use an intermittent dosing schedule with them. So they'll put somebody on the patches for a while and then they'll give them a bit of a drug holiday and they'll put them back on, or they spread the dosing out so that there is in fact a period where the drug is not in the system. And that's to limit this effect called tachyphylaxis, so the drug does have the effect that's intended. So our last slide in this set is introducing the idea of adverse drug reactions, events and effects. And in terms of adverse drug reactions, the World Health Organization has actually created a definition so that we know when we're referring to a drug reaction, an adverse drug reaction. And that is that we've got any response to a drug that is unpleasant or noxious, unintended, occurs at doses we would normally use for prophylaxis or diagnosis or therapy. It doesn't include reactions due to overdose, drug abuse or drug withdrawal, and we'll go through the classification of the ADRs when we look at the pharmacodynamics slide set. Adverse drug events, though, are events where we've had a medical intervention that is related to the use of a drug that has in fact gone wrong. So this is where the wrong patient got the wrong drug was given to a patient, perhaps the infusion pump failed or the drip bag was leaking everywhere and the full dose didn't get given in a drip setup. So an adverse drug event is related to the drug, but it's about the medical intervention, not necessarily the drug itself. Adverse effects is how they would like us to refer to side effects, and we talk about side effects, fairly colloquially, but technically we should refer to them as adverse effects. They are the effects that will be the result of giving a drug to somebody that's not related to the actual drug's target. So, for example, asthmatics use Ventolin. The generic name for Ventolin is salbutamol. Salbutamol causes the bronchi to bronchodilate to relieve the breathing problems associated with asthma. However, in high doses, it can also affect the heart. And the reason for that is that it works on beta receptors. And whilst it is very good at attaching to the beta 2 receptor that causes bronchodilation, it can also affect the beta 1 receptor in the heart. And so people who are particularly sensitive, or if the drug is, they're using it over and over and over again because they're having trouble breathing, then that dose can cause palpitations, not just the bronchodilation, which can be very uncomfortable and not help with the anxiety levels associated with having an asthma attack. So that's the completion for this slide set. We'll do the pharmacodynamics next.